Pradeep, we can start in next 2 minutes at 7:05.
Yes, sir.
Hello, Pradeep and Arvind.
Good evening, sir. So can we start?
Yes. Good evening, ladies and gentlemen. I welcome you all for the first joint symposium between Indian Academy of Neurology and Indian Stroke Association, which are especially working for the cause of stroke. You all are aware that stroke is the most common cause of disability and death in India after the cancer. And with me is my all colleagues are there, and with me is President of Indian Stroke Association, VG Pradeep Kumar, along with his team and Arvind Sharma and Jairaj Pandian, who is an international Vice President at WSO. And we got all great speaker. We got Chairperson of a Stroke subsection of Indian Academy of Neurology, Sunil Narayan. And we also has got Dr. Anand Vaishnav, who are going to speak to you. My Secretary of Indian Academy of Neurology, Professor Meenakshi Sundaram, will surely joining in some time. So I welcome all of you on this platform. This is something which we have, Indian Academy of Neurology felt that we need to have joint work together on with our subspecialty organization. And it was Salaja who took it over. She is a CME convener for Indian Academy of Neurology and has been the past president of Indian Stroke Organization. So she was the fulcrum between the two organizations to have this program come to the light today on 16th of June. So with that note, I welcome you all and thank the whole committee of Indian Stroke Association to listen to us and cooperate and come forward with this joint symposium. I hand over to Pradeep Kumar for his word and then take over this session.
Thank you, sir. Dr. Nirmal Surya, President of Indian Academy of Neurology, and Secretary Dr. Meenakshi Sundaram, and the Secretary of Indian Stroke Association, Dr. Arvind Sharma, and the speakers of today, Dr. Jairaj Pandian, Dr. P.N. Shailaja, both are past presidents of Indian Stroke Association, Dr. Anand Vaishnav, and Dr. Sunil Narayan, who is a past executive committee member of Indian Stroke Association. So it's a very great moment for not only Indian Academy of Neurology, but for Indian Stroke Association as well, because in a country that's a huge country like India, where the facilities for diagnosing stroke as well as giving advanced treatment, as well as rehabilitation, everything is, the facility is lacking now. The poor resource country. So it's high time that we should make aware our own colleagues and down the line to the physicians at large regarding the various aspects of stroke and how to reduce disability and mortality, so that we will strengthen the country in a different way. So this is a great opportunity, and I can thank and congratulate again President Dr. Nirmal Surya and Dr. Meenakshi Sundaram for this great venture, and CME convener of Shailaja ma'am. And we are happy that ISA is collaborating with this event, and subsequently also will take it forward with the subsequent sessions. And we have speakers today, Dr. Jairaj Pandian, from his the principal as well as head of the Department of Neurology at CMC Ludhiana, Dr. P.N. Shailaja, the professor and head of the Department of Neurology and Stroke Unit in Sri Chitrathindal Institute, Trivandrum, Dr. Anand Vaishnav from Gujarat, Surat, and Dr. Sunil Narayan, he is a professor of neurology in JIPMER. He is past executive committee. So thank you, sir. Thank you for this opportunity and welcome you all once more on behalf of ISA also. And I request Dr. Arvind to have a 2 minutes, couple of words as Secretary of Indian Stroke Association.
Thank you, Dr. VG Pradeep, the President of Indian Stroke Association. And I would like to thank the President of Indian Academy of Neurology, Dr. Nirmal Surya, and the Secretary for Indian Academy of Neurology, Dr. U. Meenakshi Sundaram, for getting this opportunity to get the IA and ISA for the first time as a symposium. And I really congratulate both the organization to get this on board for us and for a lot of further collaboration to be needed. And thank Dr. Shalja, who is the CME convener for IAN, to get this program worked up. And I invite all the speakers. Thank you very much for accepting the invitation. And let us start the program. And Dr. Nirmal Surya, let us begin.
Yes,
yeah. So with both the presidents on board, Dr. Nirmal Surya and Dr. VG Pradeep Kumar from ISA, let us begin this symposium and not waste time because the audience is waiting for the talks. And the first, as Dr. Pradeep has already introduced all the speakers, I would like to welcome our past president from Indian Stroke Association, Dr. Jairaj Pandian, who is at present also vice president for WSO, and he need no introduction across India and the world. And he's going to speak on the rapid evaluation of acute stroke. So I welcome Dr. Jairaj Pandian to give his talk.
Yeah, thank you, Dr. Arvind Sharma. And so I'll just share my slides. Okay, can you see my slides?
Yeah, yes.
Okay, so I'm going to talk about rapid evaluation of acute stroke, primarily focusing on the pre-hospital care and also the emergency department care. So before going into the rapid evaluation, we need to know what is the current burden of stroke in our country. This is a nice review that the India-UK group we had published recently. The incidence of stroke in India ranges from 108 to 172 per 100,000, and the prevalence is from 26 to 757 per 1 lakh population. And the 1 month case fatality rate, that is the number of stroke patients who die after a month, ranges from 18% to 42%. And this is data from our Ludhiana population-based stroke registry. The incidence is about 218 per 1 lakh population. What about the mortality, stroke mortality? This is a lovely verbal autopsy study from rural Maharashtra. In about 94,000 people in the villages, about 1,599 deaths they documented, and 14.3% deaths were caused by stroke. And the crude stroke mortality rate was 121, and the adjusted age standardized stroke mortality was 191 per 1 lakh population. So stroke is the leading cause of death and accounted for 1 in 7 deaths in this rural region. So what about rural Ludhiana? From the rural population-based stroke registry, we did the verbal autopsy of all the deaths occurred in this. The total deaths reported was 1,182. The verbal autopsy, we conducted verbal autopsy in all these patients, and 237 stroke deaths we were able to document. That is 20% of the deaths that in rural Ludhiana was due to stroke. The age-adjusted mortality rate is 150 per 1 lakh. So we have a huge burden of stroke in terms of incidence, prevalence, as well as mortality. So if you look at the raw numbers, in a year, 1.8 million
Can put off your video, Jairaj.
Every 40 seconds, one Indian stroke and one stroke
Sir has got logged out.
He got logged off, I think, right? So there was a lot of disturbance going on. I thought it is on my. So
Can I ask Jairaj to put off the video? So probably that will improve.
so can we call Dr. Jairaj if we can?
Yes, I'll just do that.
Yeah, please. So
I can just give in the situation. Actually, the internet here is quite unstable. I'm also really scared. We had a chat about it with
you're talking about
Jairaj was talking. We are come for a
talking
meeting.
about Goa, right?
Yes.
Yeah.
So
So
it's a huge problem. Net is not stable.
You can share your slides with Mansi. She can play for you. That will be much better if possible.
yeah.
And video also, no, put off the video so that
Yeah. So
audio may be better.
Dr. Sunil, and you are also there. So if you can share your slides to Mansi, it will be great.
Yes.
Yeah. I think Mansi, you are able to contact him?
Yes, sir. I am just calling. The ring is going.
Okay, great. We'll wait for 2 minutes. Otherwise, we'll start the second talk and you can join.
If they can share the slide and log in from the phone, it will be much easier to, deliver the talk.
Agreed. And it is coming from a person who's using 4 laptops at once. It is right.
Sir is joining back.
Yeah.
I think, it might be a good idea to take the slides. Keep happening. Like between also, I got logged out. Now I'm back here. So hardly any control over this.
So Dr. Sunil will request you if you can possibly send this because you are also at the same place.
Yes.
Yeah. So, can I ask both the presidents if Dr. VG Pradeep and Dr. Surya, if he's unable to join, can we have the next talk now? Yeah. So if you permit, if you both permit, yeah.
Yeah, I think so.
So thank you very much, President IN and ISA. I think we'll have Dr. Jairaj for the second talk, and I would request now our own past president, Dr. P.N. Shelja, who's the professor and head for the Sri Chitra Department of Neurology, and she's the past president of Indian Stroke Association. So let us hear her talk on the etiological evaluation and the treatment of ischemic stroke. I would request Dr. Jairaj, we can have Dr. Shelja's talk and then we can have yours. And in the meanwhile, you can send the slides of yours if possible to Mansi. So is it okay, Dr. Jairaj? Yeah, Dr. Shelja, please. You can
Thank you. Thank you, Dr. Arvind. Thank you, Dr. Nirmal Surya and Dr. Pradeep and all the team members and all the IN EC for giving me this opportunity to give this talk today. And I will start. in my talk, there is a bit of an overlap between mine and Anand. So what we had a discussion, and I thought I'll confine myself to the etiological subtype, how you investigate, and partly briefly go through the management in these patients. So if you look at the etiological stroke subtypes, I'm going to talk about the ischemic stroke subtypes, the classification subsystems, the diagnosis of the stroke etiology, and briefly the management. Rest of the detailed management will be discussed by Dr. Anand. Why do we need a ischemic stroke subtyping? Because it influences the prognosis. Because we know that if a patient is having a cardioembolic stroke or a large artery atherosclerosis, the chances of the patient having a recurrent stroke is significantly high. Coming to the mortality too, we know that in large artery atherosclerosis and cardioembolic stroke, the clot burden is going to be high. And because of that, these patients tend to have large strokes and the mortality is high. In addition, it not only influences the prognosis, it influences the treatment decision making. For example, you have a large artery atherosclerosis, there is an option of carotid endarterectomy and stenting to prevent a future stroke. You have intensive medical management with dual antiplatelets and statins and anticoagulation for cardioembolic stroke. It's very important, hence, to have a ischemic stroke subtype once acute phase of the stroke is over. If you look into the different classification systems, we can see that there was the Oxfordshire Community Stroke Project and the TOAST classification. Then came the causative classification, the ASCO and the Chinese ischemic stroke classification. But we all know that, and we all tend to use the TOAST classification for our regular practice. If you look at the Oxford Community Stroke Project classification, it is mostly based on the clinical symptoms and it's in combination using the imaging. So there are 4 subtypes which are described. We know that the total anterior circulation, you have a large MCA stroke, you know that it is a total anterior circulation stroke. You have a branch occlusion, which is a PACI. And if you have an occlusion of the occlusion or a stroke in the posterior circulation, it's the posterior circulation stroke, and then comes the small penetrating artery occlusion. Coming to the TOAST classification, this is the one which has been developed in 1993. It is mainly based, it's mostly based on the etiology by combining the clinical neuroimaging. So it is more comprehensive in combining the clinical neuroimaging, cardiac evaluation, and have a vascular imaging specifically, which will help to differentiate each of this. Coming to the TOAST classification, we have the large artery atherosclerotic disease, we have the small artery occlusion, we have a cardioembolic stroke, strokes of other determined etiology, and undetermined etiology. So when we say it is probable, we know that the clinical imaging findings, all the diagnostic imaging, everything is consistent with a one stroke subtype, and we have excluded most of the other etiologies in this patient. But if it is a possible, you feel that it is mostly that stroke subtype, but other investigation studies are not done. So coming to large artery atherosclerotic disease. So if you have a patient who has got a more than 50% stenosis or occlusion of a major brain artery, or a branch, for example, it can be not only the ICA, it can be a MCA or a PCA or any of these branches, and it should be due to atherosclerotic disease. This constitutes around 30% of the ischemic stroke subtype. In the large artery atherosclerotic disease, there is the intracranial atherosclerotic disease, which we know is more common in the Asian and the African Americans. Second is the extracranial atherosclerotic disease, which is more common in the whites. And in Asian population, you tend to see more of intracranial and also a combination where we have an intracranial and extracranial atherosclerotic disease. Atherosclerosis, we know that once the patient becomes symptomatic, they have a fibrous cap with the rupture, and you have the clot formation because of the rupture, and it goes and occludes the vessel. So what causes the stroke in these patients? We can see they may be having a branch occlusion infarct, they may be having a hemodynamic infarct, or it can be a watershed territory infarct. So why is it important to know to diagnose them early by doing a vascular imaging? So this highlights the importance of having a vascular imaging for all ischemic stroke subtype patients, because that is going to give you a clue with regard to the large artery atherosclerotic disease. We know that if you have a patient with a symptomatic carotid stenosis, that is a patient who develops a TIA or stroke, and you find that you do a vascular imaging, you find there is some more than 50% stenosis of the carotid artery. We know that the early risk, even with intensive medical treatment, is significantly high. It can be in 48 hours from 5%. In 2 weeks, the risk is very high. So what are the current treatment options available in them? You have an intensive medical treatment, carotid endarterectomy and carotid stenting. Medical management, current guidelines suggest to give dual antiplatelets for these patients for 3 months. High dose statins, you control the risk factors very well, and treat them for the strict risk factor control so that you can prevent a future stroke in these patients. Coming to, we know that especially in carotid artery stenosis, it is different in vertebral artery stenosis. But if you come to carotid artery stenosis, we know that even with intensive medical treatment, especially in the first 2 weeks, and if the patients have got a higher grade stenosis, even on best medical management, they tend to have recurrent strokes. So in these patients, the standard of care is still carotid endarterectomy. This is one of our patients who had, you can see a tight carotid stenosis, a watershed territory infarct, and this is the endarterectomy done specimen. So the current guidelines advise that these patients should have an early revascularization of the carotid stenosis within 2 weeks of having a minor stroke or a TIA. So which would be the best option for treating these patients, whether it is endarterectomy or stenting? We know that there have been a lot of studies which has happened. This is in fact from the carotid stenosis trialist collaboration data of all the trials, the EVA 3S, PACE and ICSS. This data showed that the early risk of stroke, early peri-procedural risk is definitely slightly higher in the carotid stenting patients of 8.9% versus 5.8%. But if you look at the long-term risk, the long-term, either you do endarterectomy or stenting, the patients, even at 10 years, they do very well. So maybe over time, we know that the endarterectomy procedures and the devices available are significantly better now, and hence, these endarterectomies almost, this carotid artery stenting is almost becoming equivalent to carotid endarterectomy. So either options, it depends upon institute-based protocol. If you have a very good stenting endovascular team, carotid endarterectomy or stenting can be equally done with very low risk of peri-procedural risk, similar to endarterectomy. So which are the high-risk patients for carotid endarterectomy? We know that if a patient is having a contralateral IC occlusion, for example, it may be an asymptomatic IC occlusion. If you have a radiation stenosis, we never tend to do carotid endarterectomy in these patients. If they have a high cervical bifurcation, and if they have a limited C-spine mobility, and if there is a restenosis, these are the patients who are high risk for endarterectomy, and we would prefer to do stenting in these patients. And if they are a high risk anesthetic risk like cardiac failure or a severe COPD, or a patient is having a triple vessel disease with a significant coronary artery disease, and who are high risk for surgery, these are the patients who go for stenting. But if you look at the carotid stenting group, there is a small group of patients in which stenting will not be possible. For example, you have a very tortuous anatomy, if you have a significantly calcified plaque, and if you have a free-floating thrombus, they are not good candidates for stenting, and especially for peripheral occlusive disease and renal failure. So both endarterectomy and stenting are equally good. You may have to decide your selection depending upon your patient characteristics and what is the setting of the institute in which you are working, and whether you have expertise for both available or which is having the least peri-procedural risk in these patients. So coming to intracranial atherosclerotic disease, similar to extracranial atherosclerotic disease, intracranial atherosclerotic disease is also associated with significantly high risk of recurrent stroke. This is from our own data of the natural history. As you can see that the 1 week risk itself is significantly high of 8%, and it progressively still high even at 1 year. So we also found that if a patient is especially having a diffuse atherosclerotic disease, the chances
Yeah.
of the patient having
I'm actually
Dr. Sunil Narayan, can you switch off your mute your mic, please?
doing the final rearrangement. Sorry. Sorry.
So if you look at, this is also one of our recent data. This is the data which we looked at our own intracranial atherosclerotic disease patients and compared them with the US population. And as you can see here, this is a very important data which I can show you is that when we compared the two groups, there were 329 patients, almost similar from our institute and from Chicago. You can see that both groups received reperfusion therapy, but more important is that 90% of the Indian patients were on dual antiplatelets compared to only 60% of the patients were on dual antiplatelet therapy. And more recurrent stroke were seen in the US population compared to the Indian population, because this included both TIA and stroke. So all the more important to know that maybe more than 3 months also it is important to give, which Dr. Rohit is going to do his trial on restenosis to see a longer time of dual antiplatelet therapy, whether it is required for our patients or not. This is just to show you one of our patients with tight MCA stenosis, which is seen in the DSA. So coming to intracranial atherosclerotic disease, there are multiple mechanisms by which stroke happens. It can be a plaque rupture producing embolic shower. It can be a branch atheromatous disease where the plaque extends and grows into the perforator ostia and produces a large perforator territory infarct. Or it can be a severe stenosis producing a hyperperfusion related infarct. So all these patterns can be differentiated very well in the when you do the imaging. So the imaging, the pattern of the diffusion infarcts and the vessel imaging will help you to tell whether it is an intracranial atherosclerotic disease versus extracranial atherosclerotic disease, and also help us to rule out other causes of vessel stenosis. You can see here there is a thrombotic occlusion of the M1. Here you can see artery to artery embolism, a classical hemodynamic infarct, and this is a branch atheromatous infarct which is bigger than a lacunar stroke. And there sometimes patients may have a combination of hemodynamic with embolic infarcts. So what are the treatment options available in these patients? One is either go for intracranial stenting or the intensive medical treatment. We all know from the medical treatment, which is taken from the samples data, we intensively treat these patients with the dual antiplatelets and high dose statins, and have a very good risk factor control of these patients with an LDL being maintained below 70, and lifestyle modification program, especially with smoking cessation, exercise. All this has been found to be very helpful and has been shown to be effective in reducing the risk of stroke from the samples data. So this is the samples trial which showed that. So this was a study which had to be stopped early because of the significantly high risk of peri-procedural events in the stenting population compared to the medical group. But as we know that there have been a lot of issues with this trial regarding the patient selection. And from the samples data, we really learned how best to take the best patients for intracranial stenting. And this is a long-term outcome. There was no significant difference in this group. But the recent data from the WEAVE trial, where you can see that compared to the samples trial, the peri-procedural complications were significantly low. So which are the patients who are ideal candidates for selecting for the intracranial stenting? So it is important that the patient should have a recurrent event in spite of medical therapy. As a first option, stenting need not be considered. Patients having a high-grade stenosis in the symptomatic vessel, and it is always better to avoid doing stenting in the very acute phase because that increases the risk of peri-procedural stroke. Coming to cardioembolism. So when do we say a patient is having a cardioembolic stroke? You evaluate the patient and you find a cardiac source of emboli. This also contributes almost similar percentage compared to the large artery atherosclerotic disease. And as I told earlier, they have a large clot burden with big stroke and have a high mortality. And these patients have a high risk of early events unless these patients are treated with anticoagulation and they have a high mortality. If you look at the high risk and the medium risk group, it is very important to differentiate them. The high risk group are invariably needs to be treated with anticoagulation. We know all the high risk sources, especially with regard to rheumatic heart disease, bioprosthetic valve, and patients having a LA or LV thrombus and a recent myocardial infarction, and dilated cardiomyopathy, and patients having LV ejection fraction less than 28%. These are all classical cases of high risk sources. But medium risk are the patients you may have to take multiple factors into consideration before we finally decide this is a source of embolism, and then decide to treat them, especially when it comes to PFO alone, or if you have a combination with the atrial septal aneurysm. Cardioembolic stroke also, you can have a significant findings which can help you to differentiate whether it's a cardioembolic stroke from the diffusion pattern, where you see multiple tertiary infarct. You may see infarcts of varying ages. You can see here it is hypo, but you can see a normalized ADC. You may see a branch occlusion, a cortical infarct, which suggests an embolic source. And then coming to the small artery occlusion, this is the classical lacunar stroke. So where you have a very small infarct, usually it is less than 15 millimeters. It can go up to 20 millimeters, and it should be in a perforated territory and constitutes around 10 to 20% of the acute ischemic stroke. And the major problem with the lacunar stroke is that they are at increased risk of having cognitive decline, dementia, and a vascular Parkinsonian picture. So this is a classical case of a patient with a minor stroke having a diffusion abnormality and the vessels being normal. So what are the potential mechanisms of lacunar stroke? So you can diagnose them by a perforator infarct, but it is very important to do your vascular imaging and rule out there is no atherosclerotic disease, because even a small percentage of patients who are having a carotid or intracranial atherosclerotic disease can have an infarct in a perforated territory. So most common is lipohyalinosis, but as I already mentioned, they can have a picture of a branch atheromatous disease, but cardioembolism is very rare. So these are all the mechanisms of a branch atheromatous. So you can, if you see the classical small vessel disease is a lipohyalinosis where you see these small infarcts. But if you look at the classical parental, as I discussed earlier, perforator arteriolar microatheroma, or it may be a parent branch atheromatous disease, these patients have a larger infarcts, and you can differentiate them by doing a vascular imaging. Sometimes the vessel imaging may show there is a very small stenosis, and sometimes you may even require a vessel wall imaging to differentiate these patients. Coming to the stroke of undetermined etiology, this is a situation where the patient has not been evaluated completely, or after all evaluation, you may find that the patient is not having an etiology, or sometimes a patient may be having two competing etiology. For example, a patient may be having a left MCA stroke, there is a symptomatic carotid stenosis, and in addition, the patient has got an atrial fibrillation. So this is the most important group which has come up now, is the embolic stroke of undetermined source, where we need to identify these groups. So this actually comes in the undetermined groups. It is an overlap. Which are the group of patients which are coming in this? You need to decide how extensively to evaluate these patients. So you have a high-risk cardioembolic source, so you need to do a prolonged Holter monitoring to detect a paroxysmal AF in these patients. And maybe even up to 1 month you may do, and the guidelines suggest if all the evaluation is negative, you need to do a 1 month recording to pick up these paroxysmal AF patients. Then you can look for atrial cardiopathy is present in these patients or not. And if the patients are, in addition, it is also important to look for aortic arch plaques, which is very important, which is one of the important source of embolic source. And even now described as a non-stenosing atherosclerotic disease, which is described in the ESUS group, where the stenosis may not be very severe. It may be a 30 or 40% stenosis, but when you evaluate them and do a vessel wall imaging, you may find these are high-risk plaque, and rarely these may go on to produce recurrent strokes, and we may have to do endarterectomy in these patients in a select group of patients where they do not respond to medical therapy. So coming to the embolic stroke of undetermined source, so how do you diagnose them? They are ischemic stroke detected by CT or MRI, but it is very important that should not be lacunar in these patients. There should not be any intracranial or extracranial atherosclerotic disease. That is, the vessel imaging should be normal in these patients. No known cardioembolic source has been detected, and other specific causes have been excluded in these patients. So once these have been fulfilled, we know it is an embolic stroke of undetermined source. So how do you evaluate these patients? These patients' evaluation is very important. You can look at the diffusion pattern to see whether it's a patient who's having a multiple territory or a acute infarct and another old infarct. You need to you look for a paroxysmal AF and do a longer term recording. You can do a transesophageal echo to detect the aortic arch plaque, or you can do a CT angiogram from the arch so that you can detect the aortic arch atheroma. Next is the group of patients, especially in the older patients, you may have to do a malignancy workup and look for the D-dimer and the DVT and identify the malignancy group and also the hypercoagulable state group, especially in the younger patients. In a select group of patients, you may have to consider when there is a classical features to suggest Fabry's, where there is recurrent posterior circulation strokes, other features of renal dysfunction or any family history. When these features are there, you may consider a genetic testing in these patients. And if, in a select group where clinical features suggest a vasculitis or infection, you may have to go for CSF study and more extensive evaluation. So this kind of an extensive evaluation is important to detect the ESUS group. So this is from our own data of the cryptogenic stroke patients. Of about the 12.9% of patients who had a cryptogenic stroke, we identified 15% of the patients who had significant aortic arch plaque. It is very important to detect them because the treatment is intensive medical treatment and they go on to have a recurrent stroke. And at 1 year, we found that the recurrent stroke risk in the patients who are having aortic significant plaque is around 20% compared to 6% in the patients who did not have a plaque. So it is important to do a CT angiogram, or you can do a TEE to detect the aortic arch plaque in these patients. Coming to the last group of determined causes, these are all the causes which we need to look for. Arterial dissection, which can be diagnosed by vascular imaging. Cerebral vasculitis can be isolated angiitis versus secondary vasculitis, drug-induced, then hyperviscosity states, and CADASIL and other less common entities. So carotid and vertebral artery dissection is an important entity, especially in the younger population. You have a patient with a headache, neck pain, and those symptoms, and you have a vessel imaging. Because vessel imaging is very important, there is no need to do angio in these patients. Vascular imaging is enough. Non-invasive imaging is enough to detect this mural hematoma, and also the different signs are there which can detect the dissection group. From the CADIS data, from the randomized trial, it has been clearly shown that there is no difference between antiplatelet versus anticoagulation in preventing a recurrent stroke in these patients. And these patients can be treated with either antiplatelet or anticoagulation. But because of the risk of anticoagulation, it is better to treat these patients with antiplatelet. This is also from our own data where we try to compare the dual antiplatelets versus simple anticoagulation of 200 patients. This is a retrospective data which we collected. We found that there is no significant risk, difference in the risk of recurrent stroke in the patients who have been treated with anticoagulation versus antiplatelets. And hence, with the current data, we know that for carotid or vertebral artery dissection, for extracranial dissections, antiplatelets and anticoagulation has similar efficacy. So considering the risk in anticoagulation, it's better to treat these patients with antiplatelets. And in a select group of patients, when they have recurrent events, or if there is an aneurysm formation or an intracranial dissection, these are the only situations you may have to go for endovascular stenting in these patients. So which are the other specific groups? One of the other group we need to consider is the isolated CNS angiitis. Even though it is rare, this is one of our patients with a primary CNS angiitis who presented with the ACA stroke. Then the imaging was very classical. You can see small vessel ischemic changes, microbleeds, and this patient went on to have a vasculitic workup was negative. The DSA was very classical of vasculitis, and this patient we treated with cyclophosphamide and steroids, and the patient had a significant improvement. So what should be the diagnostic workup in ischemic stroke patients? You should do a brain imaging. A vascular imaging is mandatory. It is a carotid imaging. Doppler alone would not be enough. You do either a CT angio or MR angiogram because you need to look at the extracranial and the intracranial vasculature to look for atherosclerotic disease. A basic assessment of an echo, Holter, and the EKG is very important in these patients. This is our own data of 2,066 patients of the Indo-US Collaborative Stroke Project, which we did looking into the ischemic stroke subtypes, where we found that the most important subtype of patients were 30% was large artery atherosclerosis, cardioembolic also constituted around 25%, small vessel around 14%, and rest of it is constituted by the undetermined and the determined causes. This is from five centers, which included Sri Chitra, AIMS, CMC Ludhiana, NISAMS, and PGI. And if you look at the stroke subtypes, as I already mentioned, looking at the subtype is very important to know about the outcome and the mortality. And you can see that overall, the large artery atherosclerotic disease and the cardioembolic stroke had a poorer outcome, and they had more mortality compared to the patients with small vessel disease, where the outcome is excellent compared to all other groups. So to conclude, large artery atherosclerotic disease and cardioembolism stroke are the most common ischemic stroke etiology. High rate of recurrence and mortality has been reported with both large artery atherosclerosis and cardioembolic stroke subtypes. It is very important to identify the cause for the stroke, because that is going to decide the treatment in these patients and also the later recurrence risk and also the mortality and outcome. It significantly helps in guiding the treatment of individual patient and prognosticating to the family, and looking at the mechanism, and also to look at whether the patient may be having more than one mechanism is also important. Thank you.
Yeah. Dr. Pradeep, you want to say?
Yeah, that is. Thank you, ma'am, for that wonderful presentation, comprehensively covering all aspects of stroke, acute stroke, how to go about such patients as well as preventions. We'll have the question and answer at the end of the session. That is what we have announced before.
Thank you. Thank you, Dr. Vijay Pradeep. So thank you very much, Dr. Shalja, for this comprehensive presentation, which was very informative. And we'll take the questions at the end of the session. We like to have the first speaker, because of the technical difficulty, we are not able to complete the talk. So we like to have Dr. Jaraj Pandian to deliver his talk about the rapid evaluation of acute stroke.
Yeah. So I will start from where I got disconnected. Yeah, so yeah, can you see the slides now?
We can see Dr. Jaraj. Yeah, this is from your own computer, which you are presenting?
Yeah. Can you see the slides?
Yeah, we can see the slides.
Okay.
Absolutely.
So why there is a need for rapid evaluation of stroke? If we quantify what happens inside the brain, for every minute in which LVO occurs and it is untreated, the average patient loses 1.9 million neurons, 14 billion synapses, and about 12 kilometers of axonal fibers. So just imagine, if we delay the treatment, the progression of damage is so enormous, and that leads to severe disability. This is a schematic diagram where you can see the three zones. The red one is the infarct, and the blue one is the penumbra, and the green one is the oligemic zone. And the x-axis is the time. As the time progresses, if there is no revascularization, what happens is the oligemic zone and the penumbra, they develop into an infarct. And if you start the reperfusion therapy, you can salvage these two areas. So history of reperfusion therapies, why rapid evaluation is important. It all evolved from 1994, and then there was a flurry of streptokinase trials, the 3 important trials that were stopped because of increased incidence of intracellular hemorrhage. And then we had the landmark NINS trial in 1995, which proved the use of TPA between 0 to 3 hours. And then ETAS-3 in 2008 expanded to 4.5 hours. IST-3 tried to study up to 6 hours, but they could not show a positive result. Enchanted tested the low dose and standard dose RTPA with between 0 to 4.5 hours, which showed equal efficacy. And from 2018 onwards, patients with unknown onset time using advanced imaging, either MR, DWA flared mismatch, or CT, CTP, people beyond 4.5 hours and up to 9 hours, and also the extend IV unknown onset of time, you can give thrombolysis. So this is the history of advancement in the thrombolysis. So the most important thing is the recent positive trials, which started from 2014 for large vessel occlusion. So it started with the pro-urokinase trial, Mercy device, IMS3 trial. Till 2013, all these studies were negative, and the first positive study on mechanical thrombectomy was done was published in 2014. And from 2014 to 2018, we have many trials which have replicated the finding. And this table summarizes the various trials where you can look at the primary outcome, that excellent outcome as compared to without thrombectomy. And you can see the high rates of recanalization, the low rates of death, and the low rates of intracranial hemorrhage. So the NNT is about 2.1 and 2.7 based on some meta-analysis, and which has a powerful treatment effect as compared to many other interventions, including aspirin for MI or PCI for MI. So this is a very powerful intervention. But when you have such a disruptive innovation or intervention, the system, the health system is not ready to implement or not able to take care of in terms of delivering this care. So that is where it is important to know the stroke systems of care in relation to rapid evaluation of stroke patient. So if you look at the different domains of stroke systems of care, you have the community education and the prevention, the primordial and primary, and the emergency medical services, acute stroke treatment. You have the secondary prevention, stroke rehabilitation, and also the post-stroke care and continuous quality improvement. So today I'll be just focusing on the EMS response and acute stroke treatment. So what are the barriers? And if you look at LMICs like India, so you have the barriers at patient level, that is inadequate awareness. There are so many social cultural beliefs which vary from state to state, which can reduce or delay the access for acute stroke care. Then barriers at healthcare system, one is the funding, then the lack of emergency care services, non-availability of imaging in many hospitals, the lack of stroke units and technology and human resources. So components of rapid evaluation, one is the public awareness, and second is the ambulance and pre-notification, and third is the emergency department. So public awareness, we can do many things. One, at an individual level, patients who come, the relatives who come to us, you can raise awareness about stroke. Then through professional organizations, regional professional organizations like ISA, World Stroke Organization, and there are many other stroke support organizations. There are a few in India. And more importantly, it has to come through the government. Then there will be a huge impact in terms of raising public awareness of stroke. Pre-hospital ambulance services, what is the status in India? We have this 108 model in India. In many states, it has been implemented, and it is a PPP model. But however, it is not stroke specific and primarily focused on trauma services and maternity care. So there are many challenges we all know. Even if you dispatch an ambulance or the patient calls the ambulance, the traffic which will delay. So it is always better for them to reach by their own conveyance. So this is one of our earliest studies where we found that people who arrived early were people who are living close to the hospital, that's less than 10 kilometers, people who had aphasia, they reached very quickly. And the early arrival was associated with directly reaching the hospital without using any of the ambulance services. Only 12% of the cohort they came by ambulance. And Dr. Shailaja alluded to us about this particular large database that we had across the country. If you look at the number of patients who came by ambulance, was only about 1.8%, and most of them came by private transportation. And this is another study from India where they found that the percentage of people coming to hospital very early. So one is people who are reaching directly or less than 15 kilometers, people who had coronary artery disease, dense weakness, and with higher education. So in the Indian setup, of course, if you have a very good ambulance service, it may work in a smaller cities or smaller towns. You can try to establish an urban spoke model, but in large metros, probably ambulance may not be the solution for India. However, we try to develop some stroke care pathway in different regions of our country. One model is the rural population-based stroke registry model, where in 146 villages from 2 blocks in rural Ludhiana, where we train the Asha health workers to identify stroke patients in the villages. And the 108 ambulance, the staff, they were trained. So there was an integration, and the Ashas were told, and the public, we did a 6 months public awareness campaign in the villages, and we encouraged them to call 108 ambulance. The Ashas also encouraged the patients and relatives when they had stroke symptoms and signs to call 108 ambulance, besides informing them. But what did we find? If you look at the Ashas were able to identify patients within 4.5 hours in more than 50% of the time. And if you look at how many of them came by ambulance, only about 2%. About 2% of the patients, despite all the public awareness that we created, only 2% of them used ambulance to reach the hospital in time. So there is another program which is ongoing using mobile stroke unit. Instead of relatives calling an ambulance, the stroke unit with the CT scan, and in the model of mobile stroke unit reaching the home in time. So the 2 places which has been deployed, one is Tejpur, other one is in Dibrugarh, and it's funded by ICMR. And it was inaugurated by a former health minister during the COVID time. So this is the MSU. Deployed in January 2021, there was a lot of interruption due to COVID. And this is the data from Tejpur. It's not an updated data. They are getting calls for evaluating stroke patients in the small town and around the Tejpur area, including the villages. And currently, I think, if I'm correct, they have thrombolized 1 patient using the MSU in Tejpur. And this is the data before the deployment of deployment of MSU, and after the deployment of MSU, we try to look at how the patients are coming to the hospital. There are certain quality parameters also we studied. And 108 ambulance, the use is compared to Ludhiana, it's very high in this region, and there are many other private ambulance services. The onset to door, there is some reduction in the post-MSU period where patients are trying to come early. There was no difference in the door to CT time and door to needle time. There was no difference, but the thrombolysis rate in the hospitals had dramatically improved in the post-MSU period. So there are some models which are evolving in our country, but more to be done in terms of pre-hospital stroke care. So how an ambulance crew can diagnose stroke? There are many scales available. The common one is a Cincinnati pre-hospital stroke scale. It's very simple, fast. You ask the person to smile. You can look at the facial droop, the arm drift, and abnormal speech. Ask the patient to say some sentences, and abnormal speech, the patient slurs words and not able to speak or not able to understand. So this is a very simple tool that can be used. And of late there are many tools to identify LVO in the community. So where this is one stroke scale called RACE, where arm motor function, leg motor function, gaze deviation, aphasia are given higher score. Any score more than 4 means that they are more likely to have LVO. There is another score called Los Angeles Motor Scale, again focusing on the arm drift and grip strength and also the facial droop. And a score more 4 is more likely to have LVO. So I was talking about the systems of care, the stroke systems of care. So we looked at the pre-hospital, including the patient awareness. And now you need to have hospitals which are ready to receive these patients. So there are different types of hospitals. One is acute stroke ready hospital, which can be there in a rural area or in a district level hospital where there is a CT scan facility available and they can thrombolize the patient. Primary stroke center, the thrombectomy is capable, but they have a functioning stroke unit, imaging and thrombolysis program. And thrombectomy capable center, that is another new hospital's care where thrombectomy can be done, and maybe a little bit of coiling and for subarachnoid hemorrhage patients. But comprehensive stroke center is where you do everything. So this is the latest classification of stroke centers. So when you have hospitals which are ready to receive these patients, how using the ambulance, how we can reach these hospitals in time. So there are some guidelines or different methods followed. If the travel time to the comprehensive stroke center is less than 15 minutes, in addition, less than 15 additional minutes compared to the travel time to the closest primary stroke center, is better to directly transfer these patients. And there are models like drip and ship. You start the thrombolysis and ship the patient to the comprehensive stroke center where thrombectomy facilities are available, or look at a model of MSU and telestroke. So the AHA recommendation for EMS, dispatch time of less than 90 seconds, and EMS response time less than 8 minutes, on-scene time less than 15 minutes. Now, moving on to the emergency department, what we need to do in the hospital, in the emergency department. So that is where the teamwork is very, very crucial. You need to train the physician, you need to train the radiologist so that the 24/7 CT facility is available. The nurses should be trained. You need to do some point of care tests when the patient comes immediately to the emergency department. And a quick evaluation, saturation, BP, intravenous access, glucose, and ship the patient to the CT, and if possible, try to give thrombolysis if the patient is eligible, even in the CT scan. And you need to take a quick medical history, particularly for the drug history and also history of seizure, and a history of headache to exclude some of the stroke mimics. So how to reduce the door to needle time? Emergency department plays a major role. You need to create a stroke code. Stroke code can be created as a voice paging system or using a mobile app or group calls that can be done. There are many methods by which you can alert all the team members in the stroke program. You need to have proper protocol kept in place, training, imaging protocol, regular meetings with all the people, and the availability of the drug in the pharmacy. And you need to document, and maybe a monthly meeting or a quarterly meeting with all the stakeholders and reviewing all the patients that were thrombolyzed. And in a private setup in India, we need to take consent, and the payment of the drug should be discussed upfront when we decide on the thrombolysis. So what are the quality metrics in rapid evaluation of stroke? One is the door to CT time. So what is the requirement? 20 minutes in at least 50% of the patients who may be candidates for reperfusion therapies. Door to needle time of 60 minutes in more than 50% of the patients. And you can fine tune further by reducing the time to 45 minutes in more than 50% of the patients. And in patients who undergo thrombectomy, door to groin puncture time of less than 90 minutes. And in a system, in an healthcare system where the referral system is well established, target door in and door out time, less than 90 minutes in 50% of or more of acute ischemic stroke patients who are transferred. So there is a lot of newer advances in terms of reducing these quality metrics or improving these quality metrics by use of AI technology. And this is one major study published from India, the group called CURE, where they looked at more than 3 lakh CT scans, and they did there are 2 cohorts, data sets, training and validation cohort, and they were able to clearly identify using AI intracranial hemorrhage of any type and also calvarial fracture. So this is FDA approved for identification of hemorrhage and also calvarial fractures. And LVU detection and penumbra, we know from the latest thrombectomy trial, Diffuse 3, Dawn, Extend, Rapid AI was used for detection of LVO and also to calculate the mismatch volume. And there are a few other apps which are available where they integrate the radiology imaging, little bit of clinical data, the quality metrics, and also some of them extended to the post-stroke care. This is another group from UK, supported by Oxford. And this is a group from India where they are looking at different aspects of the acute workflow, including documenting some of the quality parameters. And from Calicut, I think in the recent INIC in Mumbai, Dr. Mohan Noon presented a very lovely app where it's so simple to use, and you can document all the workflow within the hospital as soon as the patient reaches the emergency department. So another important part of rapid evaluation is an ongoing quality program, and it is so important that if you want to improve the outcome of stroke patients, particularly in the acute stroke care, we need to have quality stroke centers, and this is where many countries are moving forward. And some of the examples are Get With The Guidelines in US, Angels Global Program, SIDS, and WSO quality program, and ISA we have been discussing for the last few years. Soon there will be some finalization on how we are going to move forward in terms of certifying centers in our country. In conclusion, a rapid evaluation of stroke is essential for improving acute care for stroke. This is very crucial because there are time-sensitive treatments that are available, early reperfusion therapies, and the disruptive innovation that has happened needs a lot of changes in the stroke systems of care. Unless we change, we won't be able to provide quality care to these patients. And the use of AI technology will really improve the workflow for these patients during the rapid evaluation of acute stroke. Thank you very much.
Thank you. Thank you very much, Dr. Jairaj. Dr. Vijay Pradeep.
So it's a very good expression of what is happening in the country and how we can do the best with the pre-hospital. And he has, Dr. Jairaj has already contributed with his various social intervention as well, including in the Northeast, telemedicine as well as the ambulance services and all. So I think lectures are going on in India also on pre-hospital care of acute stroke patients. It's a good lecture, and I hope that the entire audience must be benefited. Over to Arvind.
Thank you. Thank you very much, Dr. Pradeep. And Dr. Jairaj, thank you for that AI guys to which you have told the future about for the rapid evaluation. Now we move on to the next speaker, Dr. Anand Vaishnav, who is from Baroda, and he's one of the stroke neurologists in India, and he has also practiced in US. At present, he's working in Gujarat, and we'd like to have him on board for having a talk on secondary prevention of stroke. The floor is yours, Dr. Anand Vaishnav.
Can you see my screen?
Not yet.
Not yet.
Mansi, you have to help.
Yes, sir. So can you
Can you
see?
see it?
Not yet. Mansi will help you. Mansi.
Yeah, Mansi.
Yes, sir. So can you see Dr. Arvind Sharma?
Yeah, share.
Yeah. Yes.
Yes, sir. You can try this. So you're muted.
Dr. Anand, you are muted. Unmute yourself. Dr. Anand? Yeah. Yeah.
So you can minimize this screen and you can go to your folders where you have the PowerPoint saved.
Dr. Anand, you are able to hear us?
I think he is able to hear. So
Asking for the video.
so what you can do is you can click on the new share button. So when you click on the new share button, on the left hand side bottom, there is an option of share computer sound. You can uncheck that. You can uncheck that. You can also uncheck optimize screen sharing for video clip and then share your screen. So we can't hear you at all. We cannot understand at all what you're saying.
You are not muted. You are not, we can see you very well. Dr. Anand. Are you able to hear us, right?
Yes,
But
he can hear us, but we aren't able to hear him.
We are not able to hear you, Dr. Anand. So, Mansi, can you sort this out with Dr. Anand? And if the convener permits, and if the Dr. Sunil Narayan is ready, we can, if the convener, Dr. Pradeep and Dr. Nirmal Surya permit, we can have the fourth talk.
Yeah, you can go ahead.
Yeah, thank you very much. So till Mansi, please fix up the things with Dr. Anand on the backdrop. And
Yes,
may I request Dr. Sunil Narayan, are you there?
yes, sir, he is there.
Can you unmute yourself and switch on your video, please? Dr. Sunil Narayan. And Mansi, can you go to Dr. Anand and fix his thing?
Yes, sir, I'll do that.
We are not able to hear Dr. Anand, but we are not able to communicate with Dr. Sunil Narayan also. Dr. Sunil Narayan, are you there?
I will check with him also. Actually, he sent a message saying that he has found stable room with good.
He written that on the chat. He's sorted out.
Yes,
So
yes.
I'm just trying to reach him. And till then, you can fix up Dr. Anand Vaishnav.
Shall we take some questions in meanwhile then?
Yes, yes, yes. So, yeah.
There are a couple of questions in the chat box.
I think Mansi, Anand is calling me. So can you give him a call, please? I will take because I relogged.
Yes.
Yeah, please give him a call. So I'm sorry, Dr. Pradeep, you have to help me in that because I logged off from the laptop, so I cannot see the Q&A here because Dr.
I will read that.
Yeah, please.
During secondary prevention, treatment with statins, many times we encounter very low LDL and total cholesterol, but also very low HDL, causing patient concern. What should be the management strategy in such cases? That is question number 1.
I think it is for Dr. P.N. Shalja. She can give some light on that.
So
when I click on mute,
can I? Okay, so if you look at the role of statins, we know that if you look at the guidelines, what we are following is from the Sampras data. So patients are started on high dose statins. Most of our patients do not tolerate more than 40, but you can go up to 80 milligram as per the guidelines. High dose is 80. And if you can see that in these patients, the guidelines advise that the LDL is kept below 70. And we know that sometimes some of these patients, it goes significantly low. So at 3 months, we try to bring them down, looking at the LDL values and make your decision. But sometimes the low HDL is a concern. So in those patients, it is advisable to tell them to have exercise and other things which are likely to improve upon the HDL in these patients. Coming to the next question is, what is the ideal dosing strategy for clopidogrel during acute stroke? And what is the loading dose? 25 milligram once or twice daily, no clear-cut guidelines. So I think the guidelines is clear with regard to that. What we are actually following, we know that treating these patients in the dual antiplatelets with 300 of aspirin or 150 of aspirin, and keep on.
And now I can.
Anand, can you mute? Can you mute? Oh, he won't be able to hear. Okay. Okay.
Anand, can you please mute, please? Anand, can you hear us? Mute yourself, please, when you are rectifying the things. Please mute yourself. Yeah, thank you. Yeah, Dr. Shalja, sorry for that. Please.
So in these patients, we actually follow what is the data from the CHANCE, where 300 milligram of clopidogrel plus 300 aspirin is given, following which the patients are kept on 75 clopidogrel, and you can decide on the aspirin of about 150 or whatever dose which you can prefer. And this is given for a period of 21 days. The main thing is what should be the loading dose of clopidogrel is the only concern which has come up. As we know, if you compare the CHANCE data and the POINT data, the POINT trial has used a loading dose of 600 milligram. And we know that from that data, we found that the bleed risk was significantly high in those patients. So we never use loading of more than 300 milligram. In our setup for all patients, the main difference or where the guideline is not very clear is whether you do the loading dose of clopidogrel for all patients irrespective of the stroke subtype. That is the main concern. So as per the guidelines, they have used this for all the stroke subtypes. But we, as if you ask from my personal level, we tend to give, if a patient is a lacunar stroke, I won't be very aggressive in giving a 300 of clopidogrel in this patient. But all patients where the etiology is a large artery atherosclerotic disease or undetermined, you do not know the cause, in all these patients, we tend to give a loading of 300 milligram and then keep them on 75 milligram of clopidogrel. And coming to the minimum duration of Holter, so if you look at the duration of recording required to detect paroxysmal atrial fibrillation, we know that as the duration of the recording increases, the chances of picking up a paroxysmal AF is likely to be higher. But if you look at the guideline, you can go up to 1 month and do the monitoring in these patients. But if you look in India, we find that most of these patients have got only the recording which is available with us is only a 1 week recording. And unless the patient is, we are very strongly suspecting, you can even extend it up to 2 weeks. But the guidelines say you can extend up to 1 month, because the more the duration of recording, the more the chances of picking up paroxysmal.
So thank you very much. Mansi, if we are ready, we can start one of the talks. Possible?
So just in a minute,
Yeah, so I will take another question.
I left, right?
Which is
Okay, now
there
click on the original Zoom link.
Manoranj. And in patient with ischemic stroke due to Moya-Moya syndrome,
Open Zoom meeting.
that is secondary Moya-Moya disease or quasi-Moya, how long antiplatelet to be given, or is it contraindication, and how long, in addition to disease-modifying therapy? Dr. Shalja?
In patients with Moya-Moya disease, for a patient who's having an idiopathic Moya-Moya disease, in those patients, the treatment is a single antiplatelet. The antiplatelets, there is no specific guideline how long to treat, but we all tend to keep the patients on long-term antiplatelet therapy. And as you know, the ideal treatment for this antiplatelets, we do not know what is the benefit of giving antiplatelet in these patients. Definitely, all these patients would require revascularization, which is the only treatment which is going to reduce the risk of future stroke in these patients. Coming to secondary Moya-Moya disease, that is going to depend upon what is the cause for the Moya-Moya, even large artery atherosclerotic disease, vasculitis. There are a lot of secondary causes. So you may have to decide on the treatment depending upon what is the cause for the Moya-Moya disease.
Thank you. So
there is one more question actually to Dr.
Can I add one doubt? Because some people say that in adult, Moya-Moya presents as intracranial hemorrhage, and in children they present more of ischemic strokes. So will it be hampering or increasing the risk of hemorrhage if you carry on with antiplatelet to the adult life?
If a patient is having a ischemic, as Dr. Pradeep told, that is what we see also. Adult patients tend to have more of a bleed presentation, but we tend to see a lot of patients with adults also having a ischemic presentation in our setup. If a patient has got an ischemic setup, they are kept on antiplatelet, single antiplatelet. But if they had a hemorrhagic presentation, we do not keep them on antiplatelet. And these patients, either whether it is ischemic event or hemorrhagic, it is always better to keep do surgery for these patients. There is no data to show that in patients with antiplatelet treatment, it increases the risk of bleed.
Thank you, ma'am.
Thank you. Thank you for those answers. And I think we move on to the third talk and things are rectified. And I would give the hats up to Dr. Sunil Narayan also to be there for the fourth talk, and start the third talk by Dr. Anand Vaishnav. I already introduced him on secondary prevention of acute stroke. Secondary prevention of stroke.
Yeah, can you hear me?
Yes.
All right. I was, going through the Chrome, through the email, and that was the problem. So, okay, let's start. So I'm going to talk on secondary prevention of stroke, and I would like to, thank Indian Academy of Neurology as well as, the Indian Stroke Association. So the outline of my talk, not necessarily in that order, again, it's a secondary prevention talk, a little brief introduction. We'll talk about risk factors, specifically hypertension and dyslipidemia or hyperlipidemia. We'll talk about antiplatelet agents, warfarin and the DOACs. I think Dr. Selja has already talked about carotid stenosis, and I'll just put a word or two in, and specifically intracranial atherosclerosis, because it's very much common and close to our heart, especially having practiced in the West and now in the East, where it's a completely different ballgame. And then in summary, I think in the absence of extensive class 1 level A evidence, not many do we have a class 1 level A evidence. How do I manage with the Indian differences in epidemiology, and specifically, how do we do with the setting that we have? And then what are future trials or thoughts that we need to look forward to? I think Dr. Selja has talked about, stroke subtypes, large vessel, small vessel, cardioembolic, and then you talk about cryptogenic, and there's a lot of talk about cryptogenic now being truly cryptogenic versus, embolic source, embolic stroke of undetermined source. And I think she's mentioned it, so let's move ahead. So let's talk about risk factors of stroke. Now, I think all of you know these two papers, one was published in Lancet Neurology in 2016, and then the interstroke paper in Lancet 2010. These are the common risk factors of stroke that we talk about. The most important one, number one, and I always like to put in capital letters, is hypertension, hypertension, and hypertension. Because if you theoretically take care of hypertension today, 50% of strokes would decrease. I think other important ones, each one of them is important. I think lifestyle changes, we'll talk about that. No smoking, limited alcohol, physical inactivity. We'll talk about dyslipidemia, specifically diet and how much LDL and how do we target it. And then cardiac causes. Gujarat, sometimes I joke, in Gujarat that I think there is prohibition in Gujarat. It's on the contrary, it's the opposite at times. So again, alcohol should be limited. So lifestyle changes. Let's be honest. There's very limited study, in the field of ischemic stroke as far as lifestyle changes is concerned. So what we have are your cardiac or atherosclerotic cardiovascular disease lifestyle changes. Mediterranean diet. Dietary advice for stopping hypertension. I mean, does not work in our setting. Olive oil, nuts, does not work. So how do we do in the Indian setting? And this is what I'll tell my patients, I'll talk to in a minute. High consumption of fibers, fruits, vegetables, less sweets, smoking cessation, and minimal alcohol, or just don't have it. But to be more pragmatic, educate the patient. When we tell patients, have 2.5 grams of salt a day or 4 grams of salt a day, they do not understand. So this is what I tell them. Ideally, what you should have is around 2 to 3 grams of sodium, which comes to 6 grams of salt. Or more importantly, I think the way to explain them is two moderate sized samosas. If you talk about that, that is equivalent to 1 gram of sodium. So, or technically half teaspoon of salt. So technically for somebody who has hypertension, the amount of salt he should have in a day is less than 1 teaspoon. I think that is what we need to emphasize. Telling them about grams of sodium or salt will not do. Less than 1 teaspoon of salt a day for those who are hypertensive, who need to get their blood pressure numbers down. Measure your own BP. That's another advice I give. Don't come to your doctor's office once every 3 months. Measure your own BP. This is in patients who are educated. Bring your machine to your office. We check with my machine, your machine, and we know where we calibrate. Groundnut and sunflower oil are the oils that have much more monosaturated and unsaturated fats rather than polysaturated. So what for our patients, get groundnut oil and sunflower oil for our patients, which is out in your neighboring kirana store or through an online pivot. No smoking, alcohol limit, and regular exercise. So those are lifestyle changes. We need to talk in their local language rather than talking about Mediterranean diet. So now let's talk about hypertension. I think the reference is down at the bottom. This was the 2017 American Heart and American College of Cardiology guidelines. We talked about low self-dilate, less than 1 teaspoon of salt a day, diet rich in fruits, vegetables, and low dairy products, limited alcohol, and regular physical activity. So let's talk about what numbers do we keep. And this is where things get a little bit murkier. This is a paper, JAMA Neurology 2019, which looked at meta-analysis of 4 clinical trials. The trials were not perfect, and meta-analysis in most cases is never perfect, because what they do is they take trials, good, bad, and heterogeneous trials. So here they looked at 4 trials where the definition of intensive blood pressure was between 120 and 130. Some had less than 120, some had less than 130, and they grouped them into one group versus less than 140. And what they found that there was a significant reduction in recurrent stroke with benefiting intensive versus standard target. But the question then comes in an Indian setting. This is Western data where there are a lot of cardioembolic and carotid, cervical carotid stenosis. What about our intracranial stenosis, which is significantly higher in our country, in a tropical country, where, you're bound to, if you go out, lack of air condition, you are going to have 8 or 10 blood pressure points less in the setting of intracranial stenosis. And then the Western guidelines, United States, they talk about diuretics. Giving diuretics to Indian patients, the first or second line just does not work. I think those are practical constraints which you and I face in the practice here. So something to keep at the back of the mind. And because of all those issues, you are not getting a class 1 level A evidence as far as target blood pressure is concerned. So how do I manage it? Now, other thing I wanted to mark is, and for those who are really interested, there is a very nice paper which was published a couple of months ago. It was in a journal named Cardiology Discovery, where it looked at large vessel atherosclerosis and hypertension. What numbers are good? And they look at multiple trials. The NACET study, the WASET, which was the warfarin versus aspirin for symptomatic intracranial disease, the Mark Chimowitz trial, and the PROFESS trial. And what they found out, in fact, is that a good number of patients, if you kept the blood pressure less than 130 or less than 120, was more harmful. Again, a small subgroup analysis, and therefore it is important we don't rush into keeping, especially in our tropical weather, to keep a blood pressure less than 130. Again, you have to be a little bit pragmatic, but don't jump onto guidelines of 140 without knowing what is the status of large vessels, their educational status, and the tropical state of our country. There is a study which is going on. It is a European-Chinese study. The trial has finished. We are waiting for the results, and that may answer some of those questions. and that is the European Chinese hypertension trial. So how do I manage hypertension in our setup? So the aim of blood pressure that I keep in my practice is systolic blood pressure of 140. I do not worry that much about diastolic blood pressure. Now, if you look at the guidelines, the published in AHA guidelines last year, 2020, when they talk about a blood pressure less than 130/80. But class of recommendation 1. But what is level of evidence? Because these are not so great quality, multiple randomized trials, but not of the best quality. So they talk about 130/80. In our practice, and I think I'm open to critique or criticism, I try to keep it less than 140/90. Yes, the exception being lacunar stroke. There was a brilliant trial which is known as the secondary prevention of small subcortical stroke, published in NEJM, and then the subgroup analysis in Lancet, which showed that in lacunar stroke patients, absence of large vessel disease and truly a small lacune, target of blood pressure less than 130 is pretty good, and it also decreases intracerebral hemorrhage. And the other thing, as I said, encourage patients to measure their own blood pressure. What about if somebody is diabetic? 10 points less. Target of systolic blood pressure less than 130. Again, I am, and I think probably a lot of us are affected by intracranial stenosis for our patients. And for those patients, I try to target towards 140. But for other patients, diabetes and hypertension, target of less than 130. Diabetes, no secondary stroke prevention trial. So what we have in stroke are similarly what we have from your atherosclerotic cardiovascular guidelines. Hemoglobin A1C of less than 7, systolic blood pressure less than 130, and LDL less than 70. For those who want to read about diabetes and stroke, there is a very one nice, simple editorial by Walter Kernan, who was the principal investigator of the IRIS study, which was pogletazone and stroke. And it just tells it a little bit complex. I think let us target towards an LDL less than 170 and a systolic blood pressure less than 130. That's the way I do it. Hyperlipidemia. Thank God, we have 2 trials, specifically directed towards good stroke outcomes. One was the Sparkle study, 2006. And the targets, treat stroke to target study 2020. Having said that, role of fibrates, ezetimibe, and the PCSK9 inhibitors have not been studied in stroke. So Sparkle study, New England Journal of Medicine, this was a time where you could give placebo to patients with hyperlipidemia. Atorvastatin 80 milligrams with placebo, and what you had was a 16% relative risk reduction. Numbers not as impressive because this was over a period of 5 years. But let's look at the treat stroke to target trial. I think this was a very pragmatic, practical trial. What they did is, rather than agents, they included statins, and if you need it, you could also include ezetimibe. Target LDL less than 70 or between 90 and 110, and you can see the results. So this was a fairly successful trial. And I think for the last couple of years, I think irrespective of whether it's a large vessel stroke or a lacunar stroke, I've had a mild paradigm shift in my practice where I now target LDL to less than 70 in all stroke patients, ischemic stroke patients. So how do I treat LDL less than 70? We talk about lifestyle risk factors, weight reduction, fruit, vegetables, high fiber diet. And as I said, this is one of those rare things where we have a class 1 level A evidence of keeping an LDL less than 70 in all ischemic stroke patients. Antiplatelet agents, we know the agents. Aspirin, 75 milligrams, 150 milligrams. What we use, clopidogrel, Capri trial, we have been using 75 milligrams all through. Dipyridamol and extended release dipyridamol. Dipyridamol, extended release, and aspirin combination is not much used now because of the issue of headache. And number 1, the PROFESS trial, which compared it to clopidogrel, and there was not much evidence, but something to keep at the back. Cilastazol has some promise because it has a vasodilatory effect and probably may have some role in atherosclerotic patients, including intracranial atherosclerosis. What is the problem with cilastazol? It's only been studied in Japan mainly. So there are more trials need to be done and therefore not used as much. I sometimes use it in intracranial stenosis patients. And ticagrelor, we'll talk about the Socrates and the Thales trial. So we know the mechanism of actions, aspirin, a COX-1 inhibitor, your clopidogrel and ticagrelor are your ADP receptor antagonists, and then a phosphodiesterase inhibitor like cilastazol. So antiplatelet agents, let's compare one agent to other. Dual antiplatelet agents, is there any role in long-term prevention as well as in a hyperacute setting? And then I think a recent interesting concept, we'll talk about the chance to study antiplatelet failure and antiplatelet resistance. So the Capri study was a study comparing aspirin to clopidogrel, and as far as stroke was concerned, no significant benefit of one versus other. The trial was positive, 8.7% was a relative risk reduction, but this was significantly affected by peripheral vascular disease. So what is my point about clopidogrel? Great drug, but I think, benefit in stroke patients, for recurrent stroke, probably not as much as beneficial as aspirin, but a good agent to use. This is the aspirin versus extended release dipyridamole and aspirin combination. And this trial had initial promise in the late 90s. And if you look at compare, the aspirin stroke rate, was 12.5% versus the dipyridamole and aspirin combination was 9.5%. So at that time in late 1990s and early 2000, a lot of us who have been practicing that long, there's a lot of promise because there's a 20% difference between the two agents. But then PROFESS study came out, which was combining clopidogrel versus this combination, and that did not show any benefit. So for all practical purposes, for the last few years, we've been using it very less. What about ticagrelor? So this is ticagrelor versus aspirin. This was a study done in an acute setting within 24 hours, and in part because ticagrelor was originally studied in acute coronary syndrome. So they've only looked in stroke mainly for acute 24-hour strokes. And if you look at the results of the trial, ischemic stroke 5.8% in the ticagrelor group versus aspirin was 6.7%. Yes, some benefit. I think the confidence interval just touched 1, but I think there is some promise. A small problem with ticagrelor was not major bleeding, but small amount of bleeding was significantly higher, and we'll talk about that when we talk about the tail study. So there's a little bit of reluctance, and we need more study and more definition to know whether ticagrelor is truly safe as far as intracranial bleeding is concerned. But I think some promise in this agent for sure, in days to come. Maybe something to challenge clopidogrel, especially one with clopidogrel resistance. What about dual antiplatelet agents versus single antiplatelet agents for long-term secondary stroke prevention? We are going to talk about hyperacute stage in the next slides. 2 trials, the SPSP study in New England Journal of Medicine published 2012, and the progress in the MAX study 2004. No benefit of combining aspirin and clopidogrel versus a single antiplatelet agent for long-term secondary stroke prevention. I'm talking about not the first month. Again, so long-term secondary stroke prevention, again, this did not include intracranial stenosis. Only a small percent of patients were there, done in the Western world where intracranial stenosis is less than 5%. So long-term dual antiplatelet agents for a complete mix of stroke, the answer is no. 2 trials we have. But that was secondary stroke prevention long-term. What about dual antiplatelet agents in an hyperacute setting? And I think that has been a paradigm shift. Again, like LDL cholesterol for a lot of us who practice, you had the CHANCE study, you had the POINT study, and then the TAIL study, which was ticagrelor, plus aspirin, compared to aspirin alone. And I have a nice slide that I made on my own. The references are there. The CHANCE study was 2013. The POINT study 2018 and 20. And if you look at, they all were done within the first 24 hours. The only difference in POINT, and one of you asked a question about clopidogrel loading. I usually in first 12 hours, if somebody comes with a minor stroke or TIA, I load up with 300 milligrams of clopidogrel along with aspirin, rather than 600 for the worry of bleeding. And ticagrelor loading is 180 milligrams. And if you look at the results of the study, all the 3, if you look at the results, ischemic stroke, single antiplatelet, this was single antiplatelet versus dual antiplatelet. Dual antiplatelet, the strokes at 90 days were significantly less as compared to single antiplatelet agent, clopidogrel plus aspirin or aspirin plus ticagrelor. Genetic study was done only in the CHANCE study, which was the Chinese study. So let's talk about what are the issues that come out. Antiplatelet resistance. Chinese people have done a lot of work with antiplatelet resistance, and it is known that Asians tend to have more antiplatelet resistance. They did a subgroup study of the CHANCE study, which was the Chinese study, and they found out that patients who are carriers of the CYP2C19 loss of function allele, again, big words, don't get confused. What this means that this causes clopidogrel to function less. So these are patients who have this carrier of this particular allele, their clopidogrel will not function as well. And in those patients, adding clopidogrel to aspirin versus single antiplatelet agent did not show benefit. I think a great study to show that there is this phenomenon of clopidogrel resistance, which is now proven through a genetic method measuring the CYP2C19 loss of allele function. And there was also a lesson from the Socrates study. Patients who were randomized in the Socrates study was ticagrelor versus aspirin, who were already taking aspirin, and then they were randomized to ticagrelor versus aspirin. Ticagrelor group did better, which would suggest that they probably were aspirin resistant. Again, we need larger studies to quantify whether this really works. But I think genetic studies and platelet activation is what we will have to do and learn more, and start doing in our practice as time proceeds. This is a study which was just published 3 months ago, and this is one of my favorite studies, not because of just the results. All studies are great, but this looks at ticagrelor plus aspirin. So aspirin was common, ticagrelor plus aspirin or aspirin plus clopidogrel. And what they did is they took patients who just had the CYP2 C119 loss of functional carriers, which was supposed to have a clopidogrel resistance. And guess what you find? Ticagrelor was better than clopidogrel. Ticagrelor plus aspirin was better than ticagrelor plus clopidogrel, because those patients most likely had clopidogrel resistance as measured by the CYP2 C119 loss of function. So I think there's a lot of meat in ticagrelor. If we are going to look at platelet activation, there's a print study done which was published in Brain Medical Journal, and this study which suggested if we start doing platelet function or genetic stuff studies, we may be able to choose patients where the benefit of ticagrelor may be more, and we do not have to worry about bleeding. Because as this trial showed, severe or moderate bleeding was same in both groups, but with ticagrelor, any bleeding was significantly higher as compared to aspirin and clopidogrel. So I think we need to tease that out, and then we can hopefully use ticagrelor more. So questions to ponder: that we need more genetics or platelet activation study, number one. Number two, ticagrelor is probably better than aspirin if you look at genetics of platelet activation studies. Or on the other side, one of you may ask you, what if somebody has high risk of bleeding, has a history of GI bleed in the past? I think clopidogrel may be better. So I think if we use genetics and platelet activation studies, we may be able, to find better answers and it benefits certain subgroups of patients a little bit more. I think in the next 5 years, we are going to read more studies about that. Silastazole, I think, is being tried. I think we need to move over beyond Japan to the rest of the world to see whether silastazole works. So chronic anticoagulation and stroke risk indicated: atrial fibrillation, the DOACs in non-valvular atrial fibrillation, mechanical valve, stroke prevention, warfarin only, hypercoagulable states. I use it if it's unprovoked and recheck. What do I mean by recheck? You check somebody's antiphospholipid antibody during the first week or two when the hospitalization or when they come see in the clinic. If it's positive, LA, anti-cardiolipin antibody and anti-beta-2-glycoprotein antibody, I repeat them at 3 months. If they then come back to be positive, I anticoagulate them. That's my process. That's the way for you are not going to get a randomized controlled trial with a 3-month follow-up, in the field of stroke. Take it from me. Possibly indicated other cardioembolic sources, covert AF is what we have talked about, but not indicated, I think, for aspirin failure or antiplatelet failure, secondary stroke prevention, and not indicated for ESUS. This basket of ESUS, which we realized that we were clumping them together, but we need to slowly get and tease out the pieces. So as of now, not indicated for ESUS, unless you obviously detect a covert atrial fibrillation. For treatment, as far as warfarin, then you have direct thrombin inhibitors and factor Xa inhibitors. And warfarin versus aspirin for atrial fibrillation, the answer is very easy. No question about it. 1,000 patients, 1 year atrial fibrillation, where stroke prevention, prevent 23 strokes. I think that's a done deal. The question is, what about warfarin versus DOACs? And the 3 DOACs that are available in India: dabigatran, apixaban, and rivaroxaban. The doses are there: 150 milligram twice a day, 5 milligram twice a day, and 20 milligram once a day. Once a day is an advantage of rivaroxaban. That's one advantage, But if age or renal function is an issue, I think that's where dabigatran has a disadvantage. Apixaban and rivaroxaban are beneficial. And if you're severely compromised, warfarin is the way to go. But for all other practical purposes, as this slide shows here, if you look at stroke or systemic embolism, whether you look at dabigatran, rivaroxaban, or apixaban, it is superior if you look at the 3 as compared to warfarin. Major bleeding, when you compare the 3 agents, apixaban is the safest of the lot. So if you're worried about somebody with high bleeding risk or dyspepsia, apixaban is a better agent. If you really want to go for stroke prevention in somebody who already has a stroke, dabigatran is probably a choice. And if you're worried about compliance, I think advantage of rivaroxaban is once a day versus the other 2 agents are twice a day. But again, all 3 are better in non-valvular AFib for secondary stroke prevention. What about timing of anticoagulation after atrial fibrillator related strokes? Now, I think if it's a TIA, you can start right away. A small lacunate state, you can start after 3 days. I think there are just 2 or 3 cases, and this was a nice article in Lancet Neurology. If it's a large cerebral infarct, and how do you define it? More than 1/3 of an MCA territory, or multiple territories, or an NIH stroke scale of 9, they talk about 9, 15, depends, 9 with a cortical stroke. And in ICH, you're given thrombolytic acute in a small stroke, and next day you have a small petechial hemorrhage or a PH1, which is a little bit larger. Those are the days where I'll tend to wait for 14 days. No right answer, but those are the guidelines that I try to do when I treat patients with some data from that paper that is out there. So cardioembolic sources, to summarize: atrial fibrillation, DOACs definitely better than warfarin. Prosthetic valves, warfarin only, INR 2.5 to 3.5. Rheumatic mitral stenosis with atrial fibrillation, no DOACs, warfarin. If somebody has a left atrial or ventricle thrombus, warfarin for 3 months, no DOACs. Repeat an echo, see what is the status, and then decide. Thrombus disappears, you can go on to antiplatelet and have the cardiologist worry about the cardiac pathology. Left atrial myxoma surgery. I think embolic stroke of undetermined source. I think Navigate and Respect study showed that the trials were negative. So unless you have a large atrium, left atrium diameter of greater than 4.6, I think antiplatelets is the way to go. And again, we are not talking about atrial fibrillation, which is detected on long-term monitoring. And there is a trial which is being done presently by Mitch Elkin, which is known as the atrial cardiopathy trial, the Arcadia trial, which is going to look at patients with high BNP or patients who have a large atrial diameter and see whether those ESUS patients benefit from apixaban or not. And that the trial is ongoing, we'll see the results. What about decreased cardiac ejection fraction? And this was a study which was, WhatsApp, which was antiplatelet agents are the way to go. There was a study WhatsApp which showed that warfarin was not beneficial. Again, in those patients, I think it's good to give a ramipril and consult the cardiologist. And I continue antiplatelet agents, unless obviously there is a thrombus which comes up on an echo. So treatment PFO and stroke, again, I think wanted to talk when you talk about cardioembolic, PFO and ischemic strokes. Studies have shown, the references are there. There were 3 studies that came out in 2017, which shows that large intra-arterial shunts or PFOs with atrial septal aneurysm, benefit of closure is seen. But here's the problem. If you look at this meta-analysis done in Journal of American Heart Association, the number needed to treat is 1 in 131 at 1 year. Again, I'm not saying what needs to be done. I think if you're somebody who can afford, do everything, you have a good technician who does it, you're truly a cryptogenic stroke, workup's completely negative, this is one to go for. But in our setting, the number needed to 1 in 3-1, you need a good cardiologist, needs to be discussed. What about symptomatic carotid stenosis? Dr. Selja has talked about it. Greater than 70%, dramatic risk reduction with surgery in the NASET trial, 50 to 69%, and greatest benefit for carotid endarterectomy with men, hemispheric symptoms, and who already have a stroke when they are taking aspirin. We need something more than that. But greater than 70% is very clear, carotid endarterectomy. This was the NASET study, old, but still gold, except that best medical treatment was not tried then. But I don't think we're going to get trials on symptomatic carotid stenosis anymore. I'm talking about symptomatic, and less than 50% no benefit. What about CREST study? And I think Dr. Selja mentioned it. I think if you looked at meta-analysis, I think what Dr. Selja mentioned, in the early meta-analysis, you'll probably see a benefit of carotid endarterectomy versus stenting. But if you look at this meta-analysis, which were done later, or a recent paper which was out, which is out in abstract, I'm waiting for the paper to come out, this was in JAC, which showed that carotid endarterectomy is the same as stenting as far as symptomatic carotid stenosis is concerned, number 1. Number 2, cost is an issue in India. For example, in the city of Baroda, carotid endarterectomy costs about 40% of what carotid artery stenting shows. And the third thing is, what is your practice pattern? If you have an interventional cardiologist or a neuroradiologist who's done a lot of stents and expertise, stent, no problem with it. So I think it's your pick, your situation, good expertise, and the way to go, and the cost to the patient. Intracranial atherosclerosis, the last 2-3 minutes, I think it's probably the commonest cause of stroke worldwide, more so because of in the Indian situation. And the WASET, which was the initial, warfarin aspirin study, showed a 15% recurrent stroke rates. And this is the Sempris study. I think Dr. Selja talked about it. Stenting versus best medical treatment. And this was the first time that they truly did a best medical treatment in terms of systolic blood pressure less than 140, diastolic blood pressure, diabetes less than 130, LDL cholesterol less than 70, antiplatelet agents dual for 3 months, and lifestyle modification programs. And you can take my word for it. When I was in US, we participated in the Sempris trial, and they were very rigid, as to how the best medical treatment arm was taken for. And the results of the trial was that compared to stenting, best medical treatment, results were better. So I think as far as intracranial atherosclerotic symptomatic stenosis is concerned, I think dual, best medical treatment, 140, LDL less than 70, good diabetes control, lifestyle modification is the way to go. In the trial and in the guidelines, which just got published a couple of months, they talked about dual antiplatelet agents for 3 months. Honestly, truth be told, open to criticism, I put dual antiplatelet agents for an indefinite period of time, do I decrease the dose of aspirin from 150 to 75 milligrams and clopidogrel 75 milligrams and keep a blood pressure a little bit higher, and our patients have done good. I think, and that probably is shown in what the paper that Dr. Selja talked about, the AIN paper. If you looked at that initial data, the stroke recurrent rate was 15% in 1 year. This was a 2014 paper. But I think we have learned that keeping dual antiplatelet agents for a longer period of time, and we also published our Baroda data, it was about 87 patients we published in the Journal of Stroke Patient, and the recurrent stroke rate on long-term dual antiplatelet agent and systolic blood pressure, not less than 140, but keeping it in the 140s a little bit higher, especially in the first 3 months, the recurrence rate was 2.3. I think similar to what the paper with Dr. Selja compared to the Chicago paper, the dual antiplatelet and keeping in our weather, tropical weather, we just do the trick. Again, not a randomized control trial, but this is what, I tend to follow, again, open to criticism. So summary of symptomatic large vessel atherosclerosis, greater than 70% CA or carotid artery stenting, its cost and expertise to decide. Less than 50 to 69% symptomatic carotid stenosis, benefit greatest for men, hemispheric symptoms, or who already had a stroke on aspirin. Early procedure needs to be done. I think Dr. Selja talked about it. And as far as intracranial atherosclerosis is concerned, best medical treatment, including lifestyle advice, is the way to go. Stenting only if a recurrent stroke on best medical treatment. Otherwise, first line of treatment is not just antiplatelet and statin, but the best medical treatment, 140, 70 hemoglobin A1C of less than 7. So this is how do I treat, lifestyle measures, very important. Talk about salt, measure blood pressure at home, systolic blood pressure less than 140. But if it is diabetes or intracranial disease, if it's diabetes less than 130, but if somebody has a symptomatic intracranial atherosclerosis, I tend to keep the blood pressure towards 140, 145, not about 150, but I want to hyperperfuse and will monitor them more closely. LDL less than 70, I think it's a paradigm shift for me. Diabetes, hemoglobin A1C less than 7. And as far as dual antiplatelet agents, again, I tend to keep dual antiplatelet agents for intracranial stenosis for indefinite period. For lacunar strokes, I may stop after 1 month or maybe 3 months. So I think that's the little bit difference against the guidelines, but I think something that I tend to do in intracranial atherosclerotic patients. So summary, I think symptomatic large vessel stenosis, we talked about carotid endarterectomy and stenting. Symptomatic intracranial atherosclerosis, dual antiplatelet agents, as I said, beyond 3 months, I go to 75 milligrams of aspirin along with 75 milligrams of clopidogrel, keep the blood pressure on the higher side. And as I said, this is a debate between our environment and the Western scenario. Cardioembolic, hypercoagulable states, warfarin, but DOACs in non-valvular atrial fibrillation, lacunar strokes, hypertension, but long-term single antiplatelet agent. And for cryptogenic strokes, I think ESUS is still being studied. We need to look forward to the Arcadia study, but for now it's antiplatelet agent. I think plaque imaging, looking at MRI, plaque hemorrhages. There was a recent paper in neurology which looked at PET imaging, which looked at FDG uptake. Those may be the way to go. So what is the future? The future is antiplatelet agents. We need to look at genetic and platelet reactivity testing. Risk-prone patients, I talked to you about the PET imaging where plaques could get this FDG uptake would happen, and those patients tended to have more strokes. So newer MRI and PET imaging techniques to detect those substenotic plaques which could cause more strokes. What about stenting? There is a Chinese study going on which may show that with better stenting and techniques, they may be able to repeat the SEMPRI study. ESUS, we need to dig deeper. And let's see what the Arcadia, the atrial cardiopathy study shows, whether that shows that apixaban or DOACs may be better. And I think I'm going to end this talk with the concept of best medical treatment, which was shown in the SEMPRIs. And for those who know me, I like this paper, which is one of the best epidemiological change in treatment paradigm that occurs during the trial, was the asymptomatic carotid surgery trial 1, Lancet 10-year follow-up study. Just read for fun. It's a great paper. Great if you like epidemiology. Thank you.
Thank you. Dr. Vijay Pradeep, want to?
Yeah, thank you, Dr. Anand Vaishnav, for that excellent presentation. We had 3 lectures in the series, first the 3 aspects of stroke, one on the rapid evaluation, second one on etiological aspects, the third one on secondary prevention. And the 4th talk was supposed to be on stroke rehabilitation. Because of technical reason, Dr. Sunil Narayan couldn't join. That's what I learned from the technical staff. So we will take a couple of questions, I think, Dr. Aravind, and then we will request Dr. Meenakshi Sundaram if he has joined, IAN Secretary. to close a vote of thanks.
Thank you. Thank you, Dr. Pradeep. And I think it is because of technical difficulty, Dr. Sunil not able to join. His talk was on stroke rehabilitation. And now we move to for the other two questions which are there. I think Dr. Anand, there is one from Dr. Vikram that many patients after starting antihypertensive has a systolic blood pressure less than 140, but diastolic is 95 to 110. How aggressive should we treat the diastolic blood pressure, since important has been given to only systolic blood pressure?
So in most cases, I only look at systolic blood pressure. I do not worry about diastolic blood pressure because diastolic blood pressure and diastolic heart failure is a different topic in itself, not studied in stroke. But as far as I'm concerned, unless there is a severe cardiomyopathy or poor ejection fraction, in that case, I'll worry about diastolic blood pressure. But if there is not a poor ejection fraction, I just target the systolic blood pressure.
Okay, great. You can unshare your slides, Dr. Anand. So all will be on screen. So another question is from Dr. Surendra Khosla, neurologist. How we can increase collateral circulation in acute ischemic stroke? Vagus nerve stimulation or sphenopalatine ganglion stimulation? I think Dr. Anand and Dr. Shalja, Dr. Jairaj can put some inputs on this, please.
So, okay, I think let's Dr. Jairaj say.
So it's an experimental area. There is some evidence that these stimulation techniques improve the circulation, and there are a few other procedures like the intra-aortic counterpulsation, like the lower segment of the body. You augment the flow, and so these are all experimental techniques which still to be proven, and these are promising, but needs more studies. Yeah.
Anand?
No, I think the sphenopalatine ganglion, again, there was some early promise shown, but I think because the initial data was not very strong, and then this was in 2005, 2006. My colleague, Dr. Pettigrew, was the principal investigator at University of Kentucky, one of the multiple sites. It never went on to the next level because the initial results were not as good. Vagal nerve, I do not know.
So I was part of that sub-study at PGI with Dr. Dheeraj. He presented the maximum patients that definitely the Israeli company which made this sphenopalatine ganglion stimulation. But for the chronic stroke and stenosis, I think ECP, like what is done in cardiac, has shown something about the collateral circulation. So we move on to the next question: how to manage a bilateral carotid critical stenosis by Vishwa Jyoti. So how to manage a bilateral carotid critical stenosis. So Dr. Shalja, so yeah.
Can I just get the question again?
So how to manage bilateral carotid critical stenosis? I think I will start answering this. Those who are symptomatic side, they have to be taken first if it is critical stenosis, and then you can do a cerebrovascular reserve. But I think more enlightenment will be given by Dr. Shalja, please.
Yes, I fully agree with you, Arvind. If you have a patient with a symptomatic carotid stenosis and there is a bilateral carotid stenosis, definitely even if the stenosis is less on the symptomatic side, that side has to be done first. For example, but if you have a patient who is having bilateral asymptomatic carotid stenosis and maybe having some hemodynamic kind of events in the form of some giddiness or other symptoms, or the patient is a candidate who is being planned for a bypass procedure, in those patients with asymptomatic bilateral high-grade stenosis, the side which is having more significant stenosis will be taken first. And also it would be worthwhile to look, if you have the facility for plaque imaging, you can even do a plaque imaging in these patients with asymptomatic carotid stenosis and look in the plaque imaging for whether there is a lipid core or whether there is an intraplaque hemorrhage, which is supposed to be the high-risk plaque characteristics. And if that is there in that site, you can probably go ahead and do the stenosis where that is there. So for that, there is no definite guidelines with regard to asymptomatic carotid stenosis.
Thank you, Dr. Shalja. Very precise answer for that. And now going to another, I think we are left 4 minutes left for the session to be closed. And the last question I can see in the Q&A is in Moya if hemorrhagic, need to evaluate small microaneurysm in pile collateral network, especially along the supraclinoid ICA. If it's branched like PCOM, anterior choroidal artery, as well as the basilar top, I think it's more like a comment, right, from Dr. Ahmed. Any more suggestions on that part?
I think that is better answered by a surgeon, but it is very important when you are doing a DSA, it is always important to look for microaneurysms in these patients, because that is one of the features which is a high risk feature. And if that is there in those patients, there is a higher risk of bleed in these patients. So other than that, I am not sure with regard to what extra we need to be careful with regard to these patients.
I will have the last question probably. Can I have
one comment?
Yeah,
I think in Moya patients of hemorrhage, I think obviously you need to, while that comment is surgical, but I think those are the patients, where you then should probably think a little bit more aggressive towards going towards an ADAMS. So I think rather than wait for a recurrent event.
Yes. I think currently with regard to the revascularization, most of the centers, especially the Japanese and the Korean series, they are going ahead and doing ST-MCA bypass with the ADAMS. Now in our center also, we are doing a combination of both, especially other than in children, when they are less than 5 years, when the superficial temporal artery is very small, we do only ADAMS in them. Otherwise, in the adults now, our surgeons also tend to do a combination of ST-MCA bypass with ADAMS in these patients.
I can have the last question, please, because many people be having both coronary as well as cerebrovascular disease. And most of these patients, cardiologists want them to be on double antiplatelets or dual antiplatelets. And for long, many patients present with stroke, minor strokes and all, but cardiologists insist that even though there is no other comorbidities like atrial fibrillation and all. So this question always comes to what will we do as far as this our guideline is concerned on the background of coronary artery disease.
Thank you. Thank you very much, Dr. Pradeep. And can we have one more question from Dr. Vishwajyoti? Can we take that? 2 minutes are there, right? So then we'll close the session by the convener's remark and finally close by the...
Arvind, I just wanted to apologize for this.
Oh, you're there. Dr. Sunil, you are there. Huh? Okay.
I am the very much, but I sent the message. No, it's a very unstable internet. There will be interruptions on and off. Yeah. That's what I'm watching. As I watch you, it comes and goes. So, I just give the choice to you.
No, thank you very much, Dr. Sunil. Your voice is also breaking. You can see that. Your voice is also breaking. So, Doctor...
all right. Okay.
Yeah, your voice is breaking, I think. So, thank you very much for that. We really...
I'll be here.
Yeah, thank you, Dr. Sunil.
So I'll be more than happy for the occasion if I'm able to get an opportunity. I'll be more than happy to give this talk. A lot of participants, 50, 55, so quite exciting. But then feel really sorry that I'm not able to interact. So I think it's better. Even the speech is very difficult for you to hear. So I think the projection and other things are going to be really troubled and interrupted frequently.
Yeah, totally understandable, Dr. Sunil. Thank you very much. Your voice is still breaking, and we really appreciate that you are tried this. And I think we'll take both the conveners, Dr. Nirmal Surya and Dr. Vijay Pradeep, to have a final word. Then I would like to ask the secretary to close.
So let me thank you for this opportunity, Arvind, with your permission. So I'm also inviting everyone to join for the midterm conference of the stroke subsection, which is coming on July 15th to 17th. So the highlights are some 2-3 workshops, one on neuro-regenerative therapy. Those who are interested in
seeing stem cell culture and this neuronal differentiations, and also some of the brain stimulation techniques like non-invasive brain stimulations as applied to stroke.
Yes, sure.
If anyone
Fantastic.
is interested, please. And there is also a research.
So, Dr. Sunil, what is happening that we are able to
I
see
think we can,
sometimes we're not able to
workshop.
see. So we just hang there and we
So,
convey to all.
yeah, I'll be able to circulate it.
Yes, sure.
Oh, you are not able to.
Yeah, because we are the things are breaking up for you.
Yeah, kindly circulate this also, and at some other point, I'll be more than happy to join in. I think I had prepared a fairly good talk, so I'm sorry that I had to disappoint more than them. I am disappointed that I'm not able to talk to your wonderful participants. Very good quality, high quality questions. So I think that was a lost opportunity for me. And, but thank you very much for this kind opportunity.
Thank you.
I think we have closing time. I
Try
think
to do some justice some other point.
I think Dr. Nirmal Surya, IAN President, who has taken initiative for this wonderful series of lectures and webinars all through this years, and I congratulate him once more, and I request sir to have a few words, closing remarks. I have already spoken enough, and then Aravind, I think Dr. Minashi Sundaram is already there. I think he will be proposing vote of thanks. Nirmal sir.
Thank you, Pradeep, and I want to thank excellent speaker. Though there has been, we apologize for technical glitch and poor internet connection, so interruption intermittently. But in spite of that, the wonderful lecture by Jairaj Pandian, Anand, and Shailaja. And what is important is the quality of questions. The questions were phenomenal from the audience, and they have been thoroughly engaged in today's webinar, and I'm glad that we are able to push forward these webinars with various organizations. I'm sure this will be available on the IAN YouTube, and those who have missed out on today's webinar, they can go on to the IAN YouTube. I would request all of you to subscribe that, because it is not only today's webinar, there are so many other webinars and programs which are available, and they will be highly useful to you. So I request one and all to please join the IAN YouTube and subscribe that. Thank you once again. Thank you to the ISA organized team of executive members and other speakers. Thank you.
Yeah, thank you.
Thank you. And I think
Thank you.
Dr. U. Meenakshi Sundaram is not there, so I'll take the opportunity as a secretary for Indian Stroke Association, and on behalf of Secretary, Indian Academy of Neurology, Dr. U. Meenakshi Sundaram, that thank the ISA office bearers, President Dr. Vijay Pradeep, and the past President Dr. Jairaj and Dr. Padma and Dr. Shailaja, and to all the executive members of Indian Stroke Association, and thank the Indian Academy of Neurology, Dr. Nirmal Surya, and Dr. Shailaja, who is the CMA convener, and all the other executive members who took this initiative. And it was a wonderful initiative and the first symposium for IAN and ISA. We'd like to have more of these, and thank you very much for participating and doing justice to this program. Thank you. Thank you.
Thank you. Good night. Good night.
Thank you. Thank you.
Good night.
Good night to all.
Good night. Thank you.